Hey, GP learners, welcome to this episode where myself and Andy are going to be talking about all the crazy things that have been happening in general practice. And we've got a fair few news stories for you to go through, as well as catching up on what myself and Andy have been up to for the past few weeks, because we've not both been around for a while. So we're going to keep you updated on everything that's happening as we tech enhance your primary care and learning. Hello, GP learners, as you join us for this rapid live stream that we put together. Kind of last minute, hasn't it felt, Andy?
Yeah, a little bit, but it's good to be back together on camera, Gandhi. People might have thought we'd fallen out because we've not been together on screen for a while, but no, it's just been the calendars not aligning. But we're here today, and I guess a few things have been happening. Last time we met was with the independent financial advisor to look at the budget, and that story sort of continued to spiral around national insurance for GP practice. So looking forward to catching up on your thoughts on that and finding out what you've been up to as well.
Yeah, well, it's been crazy busy. So for those of you that joined us for the soft start, you'll know we asked if it's been similar for you out there in general practice land, and definitely the EGP lenders are saying so. So Prash for in their atom, mad busy out there, and hi to Dustin Saint saying hi to both of us, a good friend of the channel and stuff. And we've got an interesting episode for you all. I guess we're going to go through the stuff we're going to talk about really briefly, aren't we, Andy? So what have we got coming up?
Yeah, so we're going to hear a bit about what Gandhi's been up to. Gandhi's been on his travels in all sorts of places, and also going to the LMC Conference next week. So I'm interested
tomorrow
to hear a little bit about what's happening there. I've been up to some stuff, not as exciting as Gandhi, but I'll tell you what I've been up to as well outside of the normal job. And then we'll be covering really the main story arc around the national insurance hike and how that's been affecting general practice and how that story's been developing and if we're approaching any resolution. So we picked out a few stories about that to have a look at. We've got a new shadow health secretary who's a GP, so it'd be quite interesting to have a look at that and see what he's been saying in his first few days in office in that new role, and see what Wes Streeting has been up to as well. He's been talking about tape for general practice, and we've not been here for a few weeks, but a few weeks ago he was talking about zero tolerance of failing NHS trusts, hospital league tables, naming and shaming failing hospitals, no pay rises for underperforming NHS administrators, all sorts of things like that. So I guess we're having a look at those and just seeing how we feel about those things, and also seeing how people out there feel. So please do comment and contribute, and we'll bring things onto the screen and react. Yeah,
definitely.
That sounds like a plan, Gandhi.
Sounds like a plan. So shall we get started? Actually, I'm going to switch it slightly, Andy. I'm going to go for, what have you been up to, first of all? So Andy's adventures, as I like to call it.
Well, working hard in practice. So I guess what I'm involved with, I have a place role. So I'm the deputy clinical director of our place-based partnership, the bit that sits below the ICBs, and I don't really want to say above PCNs because we've really got no levers to do PCN. Above in terms of it covers a bigger population, but really I think a slightly different role to primary care networks, really about coordinating population health and working with other partners locally, hospitals, NHS Trust that runs the mental health services, the community nursing providers, local government, voluntary sector, looking at the wider determinants of health, so that 80% of things that actually contribute to people's health outcomes, only 20% is due to the access that people have to good healthcare, isn't it, Gandhi? The other 80% is other things. So we work on things like that. So we've been getting a project around integrated neighbourhood working in Nottingham City off the ground that's going to have an initial focus on cardiovascular disease. So the idea is focusing on something which should be important to all the partner organisations, or at least something that they can have an impact on. Lots of stuff that people can get involved with in terms of prevention and treating cardiovascular disease, from voluntary sector, green spaces, good food, to things that people do in hospitals. So we've been having some meetings around that. Been getting out to some practices to talk about end-of-life care and some of the data around that to see if we can make improvements through having conversations about data. And also been doing some work on what we call the primary secondary care interface in Nottingham. So there's a group that now meet and try and improve how primary and secondary care doctors and services work together. And something interesting that we launched was something called the 5 Asks program. So it is a letter and system that wrap around that allow GPs to actually push back on inappropriate work transfer from hospitals. And the good thing about that work, Gandhi, is that it's been agreed with the hospitals. So the format of letters that will be sent back to hospital from primary care has been agreed with hospital leadership. And there's a group of people who are monitoring and looking at those letters. They'll be audited so that we can look for trends in terms of things that are happening, things that happen often, and take action, have some continuous improvement around that. I had more to say than I thought, Gandhi.
You did.
Yeah.
And I guess for those people watching, you may want to know more, particularly about that 5-letter ASK stuff, because actually, to some it may seem like an extension of the Quality Matter stuff by the BMA that happened quite a few years back. But I guess these have been co-produced with secondary care. That's one of the key differences. I think the Quality Matters were as well, but specifically locally. So
locally agreed.
From Nottingham and Nottinghamshire, definitely have a look at that. It's on the F12 platforms and stuff that we use. But I think if there are other areas that want to adopt that kind of model, it's really interesting to see how that's going to work, because I think it's just starting officially next week, isn't it, Andy?
Yeah, well, it's live now. There's been at least one letter gone through this week, so it is working. And the hospital administrator, who's responsible for it, has viewed that and discussed it with the group that's looking after it. Maybe we should get Nick on, actually. Nick Bolly, a local doctor, has really kind of spearheaded that, so we could get him on the podcast.
Sounds like a plan. I mean, the interface stuff has definitely been a hot topic news story recently. It's something that a lot of people are talking about. But yeah, we can absolutely look at covering that another time. I guess whilst Andy's been doing all of that, I've been...
What have you been doing, Andy?
Well, I've been traveling a lot. So I've actually been down... After tomorrow, I would have been down to London 4 times in the past month, which is a huge amount for me. But I've been to various other places as well. So I missed last week when Andy went live talking about the updates and stuff that he was covering, partly because I was coming back from London from a medical directors meeting. Saturday, I was at Lincoln LMC's conference, which was an amazing session. I really enjoyed going for that. And it was kind of interesting in the sense that I had one of those celebrity moments, Andy.
Oh, who was it?
Well,
no, you were the celebrity.
Yeah, so I had this weird comment where somebody said afterwards that to the organisers, and they mentioned this afterwards, that they were really so happy that they kind of had their Taylor Swift moment in meeting Gandhi, and I was like, I'm not that big. I'm definitely not that big.
Maybe for them, maybe
for them. Okay, but it was really appreciative. But yeah, as Andy knows, I feel really shy about that kind of stuff when it gets brought up and stuff and things. The Friday, I was down at London for the Medics Money Live conference. That was lovely. I love that conference every single year. I will happily go back. It was great fun. And started talking about my kind of 5 A&Es for tech that's coming up, which we'll be covering slightly in a second. Loads more to go. Monday, Tuesday was chaos in practice because we were a few doctors down, and then yesterday, I was down in London again for the Guidelines Live conference, chairing it for Practice Index and the IGPM, and then nipped over to go see the Accurix conference, where they were talking about their prescription for the NHS, talking about integration and communication between primary and secondary care. So what you were just talking about and things. That was really cool. Got to meet a few friends and stuff. So Dave Trisker, Amar Ahmed, the team from Accurix and stuff. Nikki Kanani was there as well, so I got to say hi to her, a few people and things. It was a great session, really enjoyed it. Had to run out halfway through to get back for today, back at work, and then tomorrow LMC England conference, and that's going to be spicy. We're going to talk about that in a second.
Well, I was going to ask you about the LMC England conference, because there's a number of things brewing, isn't there? I mean, what are going to be some of the hot topics on the agenda, Gandhi? And are you going to come back and tell us about it? Next Thursday or the Thursday after? I'm
contemplating taking my camera. I will need to confirm that I'm allowed to film stuff whilst I'm there. So I was allowed at LMC UK conference, and some of the EGP listeners may remember me covering some of that from there. But this one does feel a little bit more busy, so I don't know if I'll have the same opportunities and things. And plus, it does feel a little bit more spicy. The agenda is definitely packed and overpacked, and there's been some emergency motions as well, specifically around things like the national insurance asks and that kind of thing. I suspect there'll be something about PAs on the agenda. There has been pretty much every conference going. That would not surprise me. National insurance, I think, will dominate part of it, and absolutely collective action. And how successful is that being? What are the next steps? So I would not be surprised if following tomorrow there is some news cycle stuff around either changes to collective action or progressions or possibly next steps coming through. I know a lot of people are waiting for this stuff. I suspect tomorrow will be the news point for some of that.
Yeah, I always enjoy looking at Pulse and GP Online after the LMC conference, because it seems if you have a point to make, then get your LMC to propose that as a motion for voting, and it will often get noticed, particularly if it's passed as well.
Yeah.
So it'd be interesting to see what happens. So again, when those motions are passed, what happens after that? What's the significance?
Well, the significance, so this is the LMCs getting together to discuss the issues that their members are raising, and then where does that lead to the profession? If they are passed, they are effectively instructions to the negotiating team for what should be looked at in terms of the England contract. LMC UK is specifically around all of the UK aspects, whereas this is focused on England. So I think there'll be a lot more stuff around PCNs, because that was missing from the LMC UK conference, but then a lot of the other devolved nations and stuff don't really have PCNs. So that's why I think there was less of that when I was there back in May. I suspect there'll be more around that this time round, and various other things. But it is basically instruction to negotiating parties for the GPC committee to say, this is what you need to be focusing on in the next round of negotiations, which is obviously currently going on. So so
important stuff, but not binding, I guess. Then, Gandhi, it's an instruction to consider, but not necessarily tying their hands. So it's not bound to happen if it's voted through, essentially.
No, and I guess that's one of the things that we've seen. So, for example, there's been motions around PCNs being scrapped for many years, and still here. Various things around getting rid of the GMC, the PCSC, Capita. They've been regular ones as agenda items and stuff. Still there. So but it's more about the temperature of the profession, and I guess that will be a key one to see that comes through from that. And seeing and participating, I'm really looking forward to it. I'm proud to represent Nottinghamshire LMC as part of that's the reason why I'm going. So looking forward to see how that works.
Excellent. I guess people, if you want to suggest a motion in the chat. Obviously Gandhi won't be able to propose it, but be interested to see.
Too late, I'm afraid. All motions have been signed and sealed. And we will also be voting for our new LMC England chair and committee as well. So that's due for refresh. So they'll be up. I can't remember the names going up for it at this point, but they'll be up.
And Katie Bramall-Stainer will be there talking, I guess. We might see her create some waves or headlines.
Yep. The GPC chair speaking at LMC England conference is definitely, a 4 point of it. I expect to hear some great things from Katie.
It's a good platform to make some points, isn't it? So be really interesting to watch what she says there. So Katie Bramall-Stainer might lead us neatly into our first news article.
Big one as well. I aptly called it National Insurance Chaos. Yeah. Okay. So, do you want to take us on with this?
Well, I was just for people who've been living under a rock for the last few weeks, there was the budget that happened in October, and one of the headline changes was the increase in national insurance from 13.8% to 15%. I think I've got those figures right, and that's employers' national insurance. So that's the tax paid by employers when they employ people, and it's a proportion of their wages, essentially. So this tax won't be felt by employees directly, but it's a tax paid by employers on every single person that they employ. They also lowered the threshold at which you begin to pay that on people's wages from, I think, about £9,000 to £5,000 as well. And the effect of this, looking at sort of calculations that I guess we've run in practice, talking to other people who've run their own calculations and using some of the calculators out there, is that for an average GP practice of 10,000 patients, you're looking at an increase in the tax bill of about £30,000, sort of thereabout. Depends on the composition of your workforce, but a really significant hit. And we might talk about minimum wage and expected DDRB recommendations as well, which will also need to be funded from somewhere. But so that's what the topic is. And the story, we're going to follow an arc here, but it begins with the response from Katie Bramall-Stainer GPC chair really pushing back on this and highlighting that practices are really going to be significantly affected by this increased cost that they were not expecting, that some practices might have to reduce services, some practices might find themselves not viable and hand back their contracts, so it's a really, really big problem. I spoke for a while, Gandhi. How have you been feeling about this story?
Well, it's an interesting one because obviously the key thing that came out of this was that Rachel Reeves did mention that public service entities would be exempt from these changes. And the knock on from this has been the clarification by the Treasury that general practice is not considered a public service and is not considered part of the NHS, which is really confusing considering our only client is the NHS. Considering we work for the NHS, we are bound by rules and regulations that prevent us from doing various other things because we work for the NHS. And yet, despite that, general practice is no longer officially considered part of the NHS by both the Treasury and, interestingly, more recently, by Wes Streeting himself as well, who apparently the decision of whether or not general practice was excluded lied with him.
Yeah, so they'd announced that there is like a special fund set aside to offset these increases, as you say, for NHS bodies, and the GPs have been excluded from this. They're not eligible for this, and that's where that decision about being sort of part of the NHS has come from. Yeah, they have said that they will support general practice and to hold tight on making decisions on change, because the trouble is that obviously we're all planning our the shape of our workforce for next financial year when these things come into place. You can't get to the 1st of April and then suddenly make changes. We know that these changes to costs are coming. We don't yet know if they're going to be mitigated in any way. So you have to start making changes now. But Keir Starmer has stepped in, and Wes Streeting have said to hold your horses, and that there will be some mechanism set in place. So I guess so. KBS has talked about the need for swift. Swift.
Well, I guess just to go back to that point, Andy. So you mentioned about waiting till the end of the year. I think the problem is that many places are not able to do that. As you said, planning needs to be done, and actually, without any form of mitigation, without any certainty of increase of income from a contract negotiation and things, on my travels, speaking to many GPs and GP partners, they're all saying that basically we will have to make decisions about the staffing of our practices. And the reality is that will mean either less staff or less service, because those are the only ways to balance the books. Otherwise, closing the practice.
Yeah, because we can't put our prices up because we're paid
there are no prices.
They set the price.
Yeah, exactly. We are an employee of the NHS, which our only contract is designed and set by them. So therefore, we can't change the income that we get.
I would be really interested if people out there, have done the maths and want to give an indication as to how roughly their practice might be impacted. I think we not the actual figures for my practice, but I did some. We're about 10,000 patients, and I did some calculations using the BMA calculators. The BMA's calculator, in fact, we'll bring that onto the screen as well, to try and gauge the impact on a theoretical 10,000 patient practice, and it came out with an impact of about £30,000 with what I felt was a typical workforce. So people can use that. I think some caveats though about selecting
well, I was going to say, again, on my travels, speaking to other people, I think there's others that feel the calculator may not have included everything that it could have done. So particularly the pensions increase in cost that comes as a result of the changes in how much you pay for NI, that then has knock-on impact on pensions. So Practice Index have created another calculator which they feel is a little bit more accurate in terms of the pensions costs. I know Medics Money have created a calculator that you can use that again comes out with stuff. I think you'll get a ballpark figure. The problem is it's really complicated calculations when you do them, because it's all little moving bits and stuff, and how it works. And but definitely, I think the consistent thing we're seeing across the board, most practices are looking at significant cost increase that they will not be able to afford, that will have an impact on cash flow, and likely will mean either a reduction in service or a reduction in headcount in practices if there is no immediate information on this, to be
I think so. The
honest.
clock's ticking, isn't it? Because people are having to make recruiting decisions, that will start to impact next year to replace staff that are going or increase their headcount. And people will postpone and perhaps not make those decisions.
And
I was just going to add that the BMA calculator does enable you to submit your data, including your list size and weighted list size, to the BMA, and that data will help them in terms of their understanding the problem and negotiating sort of mitigations and solutions with NHS England, Department of Health, and the government. So I'm sure the BMA would encourage you to use that calculator to equip them with the data. Sorry, carry on, Gandhi.
I forgot what I was going to say now.
Don't worry, I know what I was going to say next, and that was this is just national insurance.
Yes,
but also there was an increase in the minimum wage from I think it was £11.44 for over 21-year-olds to £12.20, which is a significant increase again in the minimum wage, and it's gone up a lot over the last 3 years. I think almost 10% for the last few years.
And don't forget that increase in minimum wage will then have a knock-on impact on the amount of national insurance you pay, the pensions you pay. It takes everything up as well.
Absolutely. And of course, you'll have people who are supervising people on minimum wage on wages that are not that much more than minimum wage. And those people are going to want to maintain a differential between the people that they're managing. So you have to put their wages up as well. So it's not just the minimum wage workforce.
Things are doing this basically. They're going to go up and up and up, and that's sorry, I was trying to do a graph, but I can't do a graph directly whilst we're live streaming. It doesn't work that way. But I guess the other thing, already I'm hearing about some practices where they're having to take quite drastic steps. So not giving any form of Christmas bonus or present because they just can't afford it realistically. Some practices as well not giving the DDRB uplifts because they can't afford it to their staff. They're just having to say that actually we cannot afford the 6% rise that was recommended.
Well, that's that's the other thing that might come next year as well, because the uplift won't be zero by the DDRB. It might be similar 6% again. So it's quite a lot of increased staffing costs potentially coming. We've ran some figures again, looking at a theoretical 10,000 patient practice, and we thought potentially this could cost another £30,000 on top if you take account of the increase in the minimum wage, increasing some people's differential to minimum wage if they're close to minimum wage, and assuming a sort of 5 to 6% DDRB recommendation, which was not out of the question. Then that could kind of double the impact from say £30,000 for a 10,000 patient practice to £60,000, which starts to actually feel like it is affecting sustainability of practices.
And again, remembering that headcount is the key part that plays an impact in it. So, I've heard of some places where they're estimating, £100,000 plus for, 10,000 patient practice, which is an average size. So imagine, if you're talking the 25,000, the 50,000, the 100,000 patient practices, whoa, we're talking some serious money.
Absolutely. So we might come back to that arc later in the future. But there's also been a new shadow health secretary. So we had a few years where we had, several new health secretaries in the course of a few years. And we've got another Conservative holding the health brief now. Of course, they're now in opposition. So this is a new shadow health secretary, but he's a GP, which I think is really, really interesting, actually. So it's Dr. Luke Evans. He's the MP for Melton and Syston, which I think is somewhere in the Midlands, I think.
It's near Leicester, between Nottingham and Leicester.
Oh, wow. Okay. So quite local. That's interesting. So qualified as a doctor after us, Gandhi, in 2007. So the politicians are getting younger than we are. That's
wow.
Always, it hurts.
That's scary.
Finished his GP training in 2013. So he's obviously sort of gone straight through probably to GP training, looking at 2007 to 2013, and worked as a GP in the Midlands. So he's jumped straight on this issue of national insurance and GPs, and really pointing out the impact on general practice, pointing out that GPs need answers now rather than at some point in the future, because they're making decisions for next year. Calling the decision to to not include GPs in this sort of relief and mitigation scheme for NI increases from the government as a cruel anomaly.
Anomaly.
So he's really getting on that. So, but interesting to have a GP in that position.
Very much so. I think the last time we've had a GP in kind of a serious position would have been Liam Fox, I want to say.
Yeah, was he? Did he end up? Was he a GP? I know he was a doctor. You're probably right.
I can't remember. I think he was a GP. And then there was I've forgotten her name, but the one that was the Health Select Committee lead. I should not remember her name. I'm really sorry for forgetting. It is quite late.
If you're watching, put your name in the chat.
Or if you're watching and you remember who that is, what we're talking about, please put that in the chat as well for us, because I might have to Google it while we're talking, Andy. I can see a face, I just can't remember a name.
That's interesting, and I think he could make some mischief around the GP industrial action and BMA government relations potentially, given his status as a GP. So I think this will be something interesting to watch.
Mm-hmm. Definitely. So next up, what have we got, Andy?
So right, back to the NI story here. So this was it's been evolving. So this is something that was in Pulse today. NHS England willing to revisit global sum calculations if GP practices share payroll data. So I think this comes from a webinar with NHS England when people have been asking questions about the uplift to the global sum and whether it will cover increases to NI and other cost pressures on general practice. And they've suggested that they might consider doing bespoke, calculating the actual impact on specific practices costs and mitigating that if practices share their payroll details and data with NHS England. So that's interesting, isn't it?
It is.
What's your reaction to that, Gandhi? Would you share your payroll data with NHS England?
I don't know the legalities on that, first of all. So HR data is obviously quite personal for a start.
Probably anonymized, right? They're not gonna ask you to.
Is anything truly anonymized? Can you not work that out in a small to medium business?
Well, I think probably not. But people may differ, but I think you might be able to, because you often have a number of people on the same rate of pay, don't you? So you maybe could get the data to them, but I just wonder, it's a lot of data to check, isn't it? They're going to have to do spot checks or audit a certain number. I'm not sure they'd be able to directly verify everything. And also, I begin to be a little bit, I don't know, I'm a suspicious person, Gandhi, in a way, and sort of think, well, is there a longer term agenda here in terms of calculating payroll, getting that payroll data? I'm just wondering, if there's a longer term agenda here. Maybe I've got my tinfoil hat on and I'm being a bit paranoid, but yeah, I'd have worries about the practicality of policing it, whether it's correct to share that data, and is there a longer term agenda about beginning to share that payroll data with NHS England? Although people might say, if you're not doing anything wrong and there's not very, very unusually high profits for partners in your practice, then you might not worry. But that's, I guess, what they can impute from the data is partners' individual earnings potentially, and people might feel that that's never been the business of the government. And
although we already have to publish our earnings as it is, if I remember rightly.
It's true. Although I think people wonder how accurate that figure that appears on websites is, I guess. So yeah, but GP partner remuneration has always been you never know what other people make, do you? People don't know what GP partners make. Often people hide it because it's less than you think. Actually, people are often earning a lot less than they'd want you to know. So often it's in that direction as well as the other direction. But I just thought that was an interesting story and development. And I'm not sure how the BMA will react to that. What else has Wes Streeting been up to? So
he came out with a news story about cutting the red tape to cut GP bureaucracy. So I remember when I saw this headline, what it reminded me of? It was that
bureaucracy busting
Concordat, wasn't it?
Yeah, that's a very Johnsonite language, quite like Boris Johnson phrase. Yeah, so he's revealed some more details about a previous pledge to cut GP bureaucracy. I think this might have been something that he mentioned during his speech at the RCGP conference, which we were there and reacting live, and probably picked up on it at the time. And he has released some more details about how this will work, and they're currently listening to ideas and feedback, asking for ideas and feedback about ways to reduce bureaucracy for general practice. I think there is a focus on transfer of work from other places, so other government areas and secondary care. There'll be a listening phase until December, so we're nearly there, and then a testing emerging recommendations phase, December to January. Not quite sure what that means. And then the particular areas that they're going to be focusing on is medicines and prescribing, data, digital and technology, workforce training, education, contractual and financial flows, and metrics. So I guess it's just want to watch this space really, but there's an opportunity to get involved with that. And we'll link the story, which has links to how you can get involved in the show notes.
Definitely. I think there's a couple of things that come to mind for that. I'm going to sneak in with one from the IGPM. So having spent the day with the team yesterday, one of the ones we realized that potentially you could save so much time and so much money by making one tiny little change in the way that payments are made. So currently, general practice gets the CQC payments that it makes to the CQC repaid back by NHS England, but they have to be uploaded, scanned in, processed, and then reimbursed. Why doesn't it just pay it directly? One payment for the whole of general practice, and you're sorted.
Well, Gandhi, it's so that they can generate a differential between those two numbers at a point in the future. So they can put CQC can put the cost up, but they can make it not fully covered, and there'd be uproar if they transferred the whole cost back to general practice. So I take my tinfoil hat off.
Go for it
now.
Yeah. But no, it's crazy. The number of repayments and reimbursements that happen currently within the NHS, and particularly in general practice, actually, a lot of that could be managed so much more effectively and reduce it. I mean, the transaction cost alone, currently £15 per transaction is the estimated cost for a business-based transaction. So times that by 7,000 organizations, just the transaction cost alone would save several £1,000s. And that's not even factoring the time.
Yeah, I mean,
and then there's the actual money.
For those of us in rented premises, you could pay the rent directly to the landlords, particularly when it's like NHS Property Services, for example.
Yeah.
Because actually sometimes practice can get in real sort of difficulties when the rent doesn't come in on time, or there's
and
too
cash
much
flow issues that happen as a result of that because PCSE or NHS England screw up the payments.
Yeah,
we're gonna stop complaining slightly, but yeah, I think there are, it's an interesting discussion that's going to happen. I think it would be great if people do contribute to it, because I think that's going to have an impact, hopefully, in some of the stuff and things that come through. But yeah, so that was our news stories, wasn't it, Andy?
Yes. Well, there was one more. So you might remember. This is a few weeks old, actually, but I think it's quite a big one, actually, because Wes Streeting was talking about secondary care, so not primary care, but Wes Streeting was talking about packages to reform the NHS and get more efficiencies. But he was talking about things like having league tables of NHS providers, so NHS trusts and hospitals. Was talking about giving more freedom to those that perform well on those league tables. Those who performed worse, he said, they'd send hit squads, or I forget the language that they use, but basically crack teams, I think, of expert NHS managers to help improve performance, stopping pay rises for underperforming NHS managers, for example. So all sorts of things. I think some of the headlines said name and shame, but I went to the government sort of press release. They weren't using that sort of language, but sometimes people go and brief to the press and use different language when that's not in the press release when they're talking to the press. But so I thought this was interesting because we've kind of lived with league tables of various sorts in general practice, and transparency around sort of GP access data, for example, for some
1.5 million appointments a day in general practice.
Every year we look at the GP survey, and I know what we say about that every year. We say, look out for the cheap journalism that starts to rank practice in your area. Here are the worst GP practices in your local area, sort of lazy journalism pieces. So we've lived with that sort of thing in general practice. I mean, do you think secondary care has much to fear here? Or do you think this might be a way of driving improved standards for patients, helping failing trusts?
I mean, nobody wants to be at the bottom of a list, do they? That's just the reality. So I think by human emotion, it's going to have some impact. Whether it'll have a significant impact, well, the whole thing of people moving around and changing and stuff, I think the worry with that is if you look, for example, a lot of the top jobs that they have, they always say that previous experience at this level is needed. There's only a few people who have that previous experience. They're just moving somewhere else. And we've seen that, haven't we? A person who's worked in one organization failed in that organization, but then just goes and works in another organization and does exactly the same job, maybe just slightly differently.
Yeah, and the problem with lead is often you can have a bit of a doom spiral for organizations as well, where the organization is not doing well. It's not a very attractive place to go if you are developing, a good, if you're trying to curate your CV for future success, you don't necessarily want to do a very hard job in a failing hospital where you might fail there like everyone else. So I think they have to be careful that they don't have organizations entering doom spirals around this issue. Although they said the crack teams of managers are going to go and help them. So, maybe that won't happen. Probably need to wait and see and look for more details coming through in the future. So, yeah, I think that was the end of the news stories that we'd identified as piquing our interests.
So if we were going to go for a quick summary, so I got tackled on this. Andy said that sometimes our live streams are just a little bit too long and people would like a nice, quick summary of what we've covered. So how about we try that? Just before we get to that, though, shout out to Dustin Saint, who has remembered the name of the Health Select Committee person. So Sarah Wollaston, who was a GP, I believe, originally with the Tories and then went independent while she was on the Select Committee, if I remember rightly. I think so. Shout out, Dustin. Thank you for that. But yeah, Andy, shall we go for a quick summary of what we've covered today?
That's good. Right. I'm going to give you the headlines, Gandhi, and you give us our reactions to it.
Okay.
So we looked at Katie Bramall-Stamer's comments asking for a swift reassurance that the tax hikes, the national insurance increases on practices would be met with government funding and mitigated. Reaction.
So, yeah, we're waiting to hear what this will mean. Obviously, huge impact for general practice if these are not mitigated, potentially looking at either reduction in service or a reduction in headcount in practices. So it'll be interesting to see where that leads. I think, the GPC are very keen to see change in that. So many organizations, and time is ticking, isn't it, Andy?
Well, because the next headline was government to set out national insurance hike funding arrangements for GPs by the end of the year. Hold your horses. Don't make rash choices about handing back your contract, making staff redundant, or significant changes to the shape of your workforce. They are going to do something. However, it will not come in the form of the Treasury's confirmed funding that they set aside to protect the spending power of public sector, including NHS organisations, because general practice is not going to be part of that fund. The implication being, are we a true part of the NHS? Interesting.
Well, I guess that raises questions of, if we're not part of the NHS, does that mean therefore we can do other things that we've previously been told we can't do because we're part of the NHS? Like, for example, see our own patients privately if we choose to. Now there's a covenant that prevents us from doing that because we are part of the NHS. So therefore, yeah, interesting. But the key thing, like you say, is the timeline for that in terms of whole fire to the end of the year. Will this come the 31st of December? When everyone's too busy doing other stuff and things. And actually then that will have a negative impact on practices being able to manage their staff and everything else and provide service from April onwards. So we will see.
In terms of measuring the impact of the national insurance increases, which are 13.8% to 15%, and the increases in the minimum wage, 11.44 to 12.20.
And the threshold rise of national insurance as well, as you mentioned.
Or reduction. Start paying that on staff earning over £5,000 rather than £9,000. There are a few calculators out there. We named a few. There was the BMA calculator, which captures the data to strengthen the BMA's negotiating hand. You mentioned a few other organisations had calculators.
Yeah, so Medics Money have a calculator you can use. Alternatively, you can look at the Practice Index one that's on their hub website that also lets you calculate the drift. So, in terms of the minimum wage increase, that will look at that cost increase that will happen as well. And if you then want to recalculate for other members of staff, so pretty comprehensive, I must admit.
And we'd calculated an NI impact for a typical 10,000 patient practice might be about £30,000, and that if you factored increases in minimum wage and a 5 to 10% increase from DDRB recommendations for medical staff next year, that might look like a £60,000 increase for that typical 10,000 practice in total. So that is the sort of numbers that can start to threaten viability of a practice. We then talked about the new Shadow Health Secretary. Gosh, we talked about it a lot, didn't we?
We did.
Who is Dr. Luke Evans.
Luke Evans,
he's a GP, qualified as a GP in 2013, and is from the Midlands. And he's jumped straight on this issue that's affecting GPs, and I think he might make a little bit of mischief being a GP during the current GP industrial action and negotiations on GP terms and conditions between the BMA and the Department of Health. So I think that's an interesting space to watch how that evolves, and it might not be to the detriment of general practice that there's a GP in that position potentially.
Speaking of which, before that, we did actually talk about the LMC England conference, which is tomorrow at the time of us filming this episode. And I will be there. But in addition, it'll be interesting to see what comes out of that conference, and particularly the news cycles are likely to have some change points we would anticipate as a result of that conference itself and how that will impact general practice.
Gosh. And we're nearly there, Gandhi. We also talked about the comments, let's call them, from NHS England, I think during a webinar, that they might revisit global sum calculations for sort of individual practices and make good the difference if they share their payroll data with NHS England, which is interesting. It's unprecedented, something that doesn't currently happen. And I guess we identified all sorts of potential concerns, potentially around privacy, confidentiality, business sensitive information, and what the long-term goal might be of asking and holding that information. So that's an interesting story. We talked about Wes Streeting's further announcements around his efforts and measures to cut red tape in general practice, which is interesting. And the final one was just talking about Wes Streeting's announcements a few weeks ago to try and shake up the NHS, and particularly secondary care, by producing league tables of hospitals and NHS providers, more freedom to those at the top of the league tables, crack teams of expert NHS managers to help shake up those at the bottom of the league tables, freezing pay rises for NHS senior managers in underperforming areas as well. And we reflected that general practice has had sort of league tables and some elements of this sort of scrutiny for a while, but that's really interesting proposals, and we will watch this space.
So that was all the news stories. In addition to that, Andy and I covered what we've been up to for the past couple of weeks. So Andy's been doing loads of stuff in the place environment, looking at how he can look at integrated neighbourhood working and various other aspects. I've been travelling around the country, presenting at different places, and basically probably burning myself a little bit, but actually it's been kind of fun as well at the same time.
Burning bright in the glamour. Swifties and stuff and things. EGP learners are definitely out there in full force, as well as attending various conferences and at the coalface as well, tackling the fact that we've had staff shortages. In addition to that, the thing we're going to finish on, so if you want to find out about this, because I'm pretty sure there's many who do, on Wednesday the 27th of November at 12:30 on EGP Learning, we're going to be doing an AI scribe comparison video. So I'm going to show you the thumbnail for it so you can all have a quick gander. So there we go. That's what it looks like. Make sure you join us live. I've just done the demo for this today with the providers themselves because it's a really interesting way I'm going to do the live stream. Actually going to see them compared live on camera at the same time, so you can see what they're like, potentially having NHS England there join us if they get the media approval and stuff. But if not, don't worry, I've got a backup plan and stuff. And we will have some cool stuff planned for you live on that live stream, Wednesday, 27th of November.
You can get the video to join it straight after this if you want. So it will come up. Alternately, we will catch you then as we continue to tech enhance your primary care and learning. And catch you in the next episode. See you later, guys.